Well, I am beyond thrilled to introduce our keynote speaker for today. Dr. Devan Stahl is an assistant professor of religion and bioethics at Baylor University. She received her Ph.D. in healthcare ethics from St. Louis University and her Master of Divinity from Vanderbilt University. Dr. Stahl has experience teaching bioethics and medical humanities to undergraduates, medical students and residents, nursing students and veterinary students. She has also worked as a clinical ethicist in tertiary hospitals and has trained as a hospital chaplain. She's done a little bit of everything. Her research interests include disability ethics, medicine and the visual arts, and theological bioethics. Dr. Stahl's last book, Imaging and Imagining Illness, Becoming Whole in a Broken Body, is an edited volume examining the power of medical images on the experience of chronic illness and disability. She is also the host of Bioethics for the People podcast. Make sure you subscribe on wherever podcasts are found. Please help me in welcoming Dr. Devan Stahl. Oh, and also, we will have an extended period for questioning today. Lunch will not start until 12:30 instead of 12. So there'll be plenty of time for your questions. Feel free to put them in the chat, in the Q&A, or in your heads. Thank you.
Great, thanks. Well, thank you, Zach, and thank you, Palmer Theological Seminary and Eastern University for inviting me here. So for those who ask, I describe myself as a theological bioethicist. So I think about bioethics questions from the perspective of a theologian. For me, the deeper questions of bioethics: what does it mean to have a body? What is the meaning of illness? What are children for? What is the purpose of medicine? These cry out for theological responses. When I write and teach, I do so from within the Christian perspective. I consider what resources we have in the Christian tradition that can help us answer these deep, fundamental questions, as well as questions that arise within modern medicine. So what is the moral status of a person who has irreversibly lost consciousness? Am I required to keep that person on life support? Is prenatal screening a wise use of God-given medicine, or a lack of hospitality toward God's gift of children? Should our crisis standards of care demand equal treatment of all of God's children, or are our prognostic determinations part of our prudential judgment? Now, there are some theologians and bioethicists who believe that there's really no place for a theologian in clinical spaces. It's one thing to write for and about Christians and about how they should engage medical care. It's another thing to tell physicians in secular hospitals how they should treat their patients. To do so in a pluralistic society, I must either abandon my religion or I must push it on others. But I want to resist both extremes. My ethics does come through my Christian beliefs and values, just as everyone's ethics comes from their own deeply held personal beliefs about the world. But I don't need to always invoke God or the Bible to justify my ethical recommendations. My Christian beliefs are also rational and applicable to contemporary circumstances. And not only this, but my theological background can be quite helpful in many instances. One such place is in understanding and navigating the theology of our patients. We live in a pluralistic society, but one that is dominated by religious belief. There is a mismatch between the religious beliefs of many of our patients, most of whom practice some form of Christianity, and our physicians, most of whom are non-religious. Taught to be tolerant of patient beliefs, physicians often find themselves completely flummoxed when patients bring up religion. The majority of patients want to talk about religion with their physicians. In fact, most patients want their physicians to pray for them. And most physicians are unwilling. Patients often base their medical decisions on their religious beliefs, and physicians rarely know how to engage those beliefs. Nothing more quickly shuts down a conversation than a patient claiming that they want to continue aggressive medical treatment in the hopes that God will perform a miracle. And it's in these instances in which I think theological bioethicists can be especially useful. So I present at a lot of medical conferences, and if you were getting CME, I'd have to do this, but I'm also a good teacher. So I'm going to lay out my objectives for my talk today. So first, I want to classify and distinguish the most common ways that patients and their families use miracle language. So what are they talking about? Then I want to describe to you the ethical tensions that emerge when families request that clinicians continue what I'm going to call non-beneficial care or non-beneficial treatment. Sometimes this is called futile treatment, in the hopes that a miracle will occur. And then finally, to identify a set of strategies for productively engaging with patients and their families who expect miracles. So this is the ethical quandary as I see it. What do we do when patients or their families invoke miracle language? Or more specifically, they are making treatment decisions based on their hope for a miracle. And I'm mainly going to be talking about end-of-life decision-making because I think these are the situations in which physicians become very, very uncomfortable. My patient is asking that we continue something that I'm not sure I agree with because they really want to buy time for God to perform a miracle. Now, of course, the belief in miracles is not restricted to one religious tradition. I hear from patients of many different backgrounds, even some who are non-religious, who invoke miracle language. But the group who is most likely to believe in the continuing reality of the miraculous in the modern world is Christians. After all, Christians worship a God who became incarnate, performed miraculous healings, and then rose from the dead. This is a miraculous God. Centuries after the Enlightenment pushed for scientific rational explanations for natural events, many Christians continue to believe that God intervenes in nature in miraculous ways. Of course, not all contemporary Christians hold the same understanding of miracles. And I actually heard almost all of these voiced in our previous conversations this morning. So there are those who acknowledge that healing miracles occurred in biblical times for Jesus and his disciples, but they no longer occur. We now have different ways of learning and trusting in God. Then there are those who believe that God created the world to function within a set of natural laws. Most natural events then are understandable and explainable. They are how God set the world to function. And it's only in extremely rare circumstances that God will contravene those natural laws to perform a miracle. Then there are those who believe that miracles, particularly healing miracles, continue and are a sign of God's blessing in difficult times of suffering and illness. Now, such blessings can happen without us, but they are aided by our belief in God. Suffering and illness test our faith, and God's signs and wonders are available to those whose faith is unwavering. I think we heard that this morning in our student presentation. And finally, there are those who believe that miracles are all around us. We need not look to unexplainable events to find instances of healing. God is still active and present in nature, and God's signs and wonders are revealed to us when we know what we're looking for. I also heard that today. The birth of a child can feel like a miracle, even though it's not contravening the laws of nature. And wherever they fall on the spectrum of theological belief, most Americans, 79%, according to a Pew study, believe that miracles still occur today. And the majority, 57%, believe that divine intervention could save a person from death, even when physicians believe that death is imminent. I believe we also heard that today. So the majority of Americans believe that this is true. Now, surrogates who believe that God is capable of miraculously healing their loved one are more likely to doubt a physician's futility judgment. So in bioethics, we describe futile treatment as treatment that can't accomplish its goal or is highly unlikely to produce any physiological benefit. So families who doubt a physician's futility judgment are more likely to request the continuation of life-sustaining interventions despite a patient's poor prognosis. At the same time, patients who report that their spiritual needs were met by the medical team are more likely to report a high quality of life at the end of life, enroll in hospice, and they receive less aggressive end-of-life care. So clearly there is a continuing need to help clinicians engage patients who invoke the term miracle over the course of their clinical care. Of course, we know that people mean different things when they invoke miracle, and these invocations can be highly variable. So in my experience, there are at least 3 ways that patients or their surrogates might bring up miracle language. So first, it could be a benign kind of statement, something that's unlikely to happen, but you might hope for. It would be a miracle if I could keep my breakfast down. Over the course of my pregnancy, I've said this many times in the morning. Or it could be hopeful, but unlikely. It would be a 1 in a million shot that this drug would cure my mother's cancer. It would be a miracle. Or the invocation could be both hopeful and expectant. I know the doctor says that the treatment is futile, but I also know that God will save me from this illness. Now, physicians are much less likely to believe in miracles than their patients, but we can't forget that our healthcare systems and institutions are partly responsible for continuing the belief in miraculous medical events. You can see, I bet if you just looked up miracles in medicine right now, you could pull up a bunch of news stories that claimed that something miraculous happened. Or this was an ad campaign from a hospital that I used to work at, where we were trying to manage people's expectations. And then you drove by a billboard that said that nothing shall be impossible. And then we wondered why our patients were requesting such aggressive treatment when they drove by this to get to the hospital. So I'm not the first person to want to discuss miracles in healthcare. So I want to briefly review to you the advice that I see out there for our clinicians and ethicists when they encounter somebody who's requesting care on the hopes for a miracle. So one group of clinicians believes that we should engage these religious beliefs directly and always try to reframe the miracle discussion by offering alternative interpretations of the medical event. So this group believes that when clinicians, when somebody asks for medically inappropriate treatment, you should engage their religious beliefs and try to reframe their understanding of a miracle. You're saying that you're hoping for this kind of miracle. Might I suggest that a miracle might happen in a different way? So they're trying to, in fact, challenge the theological beliefs of patients or their families when they hope for a miracle. So there's another group that will take the opposite approach and say, we don't want to discuss theology with our patients. This is not really our place. We weren't trained to do this. So instead, we need to reframe these conversations in terms of hope, right? So maybe you believe in the miraculous, maybe I don't. So instead, let's just talk about our hopes for this patient. And we aren't going to really engage the religious belief in and of itself directly. Thereby, if we did that, we might place the medical team in opposition to God, and we wouldn't want to do that. So let's avoid religion altogether. And then there's a final group who wants to try to distinguish people's authentic faith in miracles from those who are just coping or in denial about what's really going on. So I think the most glaring shortcoming of these responses is that they assume to already have an adequate understanding of the miracle invocation without wading into those murky waters of the patient's unique conception of the miraculous. Another shortcoming is the lack of justification for those who argue that clinicians should engage in theological debate about miracles. So clinicians should inquire about miracle language, especially when the patient is discussing it. But arguing against a patient's conception of God in favor of another conception of God requires a lot of justification. So as a chaplain, I was always taught this is a big no-no, and especially on a person's deathbed. Trying to argue with a person that their theology is wrong on their deathbed is a really precarious thing to do. So I hope for all of those of you who are pastors and are wanting to become pastors, you're having these kind of conversations beforehand. You're preparing your patients for these conversations. It is not my role as an ethicist, and it wouldn't have been my role as a chaplain to say, your belief in miracles is quite misguided. Let me explain to you theologically how Augustine would think about this is not the time, right? So I'm unlikely to try to do that sort of thing, to try to get them to change their mind, especially if I have the goal of getting them to change their mind about the medical treatment that they're wanting. That can actually be incredibly manipulative. So instead, as a good scientist, I developed, with some collaborators, a taxonomy of ways in which people might want to talk about miracles. So this is our fun taxonomic analysis, which I promise you is not as intimidating as it looks. I think it'll actually make some intuitive sense to you. So this is based on me and my collaborators' sort of years of experience working specifically with these patients. So in this first table at the top here, you'll see the innocuous statement. So these are statements, again, like, it would be a miracle if I could keep my breakfast down. So these patients are they're not trying to direct medical care. They're using the term miracle as a word for fortuitous or unlikely event, something that they would hope for, but is unlikely to happen. So this category I won't talk about quite as much, just because I think it's not meant to change the physician's minds about anything. It's just sort of a statement of this is something very unlikely to have happened, but maybe I hope for it. So the categories I want to talk about more are the shaken and the unshaken, and this is in reference to the patient's faith. So shaken invocators discuss miracle language with struggling with their own sense of self, who God might be, and how to account for their own suffering. In other words, clinical events or their sickness has shaken their faith. And so within this group, we have existential invocators and tragic invocators. So the existential invocators pose questions like, why would God do this to me? Will a miracle ever occur? And they don't necessarily have any idea about what that miracle would look like. So their religious language is not meant as a coping strategy or as a trump card or a strategic move. They're willing to engage in conversation and self-reflection. Existential invocators have been shaken by the events that they encounter, but are eventually able to shore up their conception of who they are and what the world is. This is where we hope to get them. If they're deeply engaging these questions, we want them to meet with the ethicist, with the chaplain, to discuss what it is they're fearing and what it is they hope for. But others will remain fragmented by their experiences. They will pose existential questions that go unanswered, and so their conception of the world remains shaken. These are the tragic invocators. Shaken invocators can move between these categories depending on whether or not they're ultimately able to reestablish a sense of their worldview and who they are. But not all of those who hope for a miracle have fluctuating conceptions of themselves or God, or even a miracle. Unshaken invocators have not allowed illness to shake their worldview. So for the integrated group, their conceptions of their illness fit into their worldview and into their ecclesial tradition. They have typically a long-standing relationship with their faith community, who help act as interpreters of revelation and their world, who provide them social support and are an authoritative source of their worldview formation. So for this group, invoking the miraculous is not an instance of coping. It is a genuine response to what they're encountering, coming from a deeply held faith tradition. And the strategic invocators, on the other hand, are not expressing necessarily a long-held view. They use miracle to carve out a space for themselves beyond medicine's reach. With this mode of invocation, the invocator uses religious language to further non-religious interests. Most often, the interest in establishing or preserving decision-making authority. For these patients, the hope for a miracle is more ad hoc, rather than an application of a long-held system of belief. They're not struggling with their relationship with the divine, and their invocation is not rooted in any particular religious tradition. These invocators are usually concerned with their rights, and discussing their worldview is often fruitless. So I in no way want to demean this group of people. The hospital can be an incredibly frustrating space. Many people feel dehumanized by their experience in the hospital. They can feel like they aren't being heard. Using religion or miracle language often helps them gain or regain a sense of power and control over a situation where they feel like they've lost control. And I'm incredibly sympathetic to this population. The reason to differentiate them from other groups of people is that their motivations for using miracle language are different, and the ethical response to them should then also be different. So today I want to focus on the shaken and the unshaken miracle invocators in end-of-life situations. How should we respond as ethicists, chaplains, clinicians, or clergy depends on how the invocator, the patient or their surrogate, is using the word miracle. Only once we know how and why they're using the word can we tailor our responses to them. So to discern what categories the invocator may fall into, it's important to ask questions like, what do you mean by miracle? I know that sounds so simple, nobody ever asks. As soon as somebody says the word miracle, everyone writes them off. They're waiting for a miracle, you can't talk to them. What do you mean by miracle? Is there a religious community that could help you during this hard time? For the shaken invocator, the former question might be met with uncertainty or skepticism. She may continue to seek a miracle, but what she means by this hope, or how much this hope might influence clinical care, will be unclear for both the invocator and others. Unshaken invocators will be clear in what they mean by a miracle, but again, it will either be an authentic application of their belief system or a way to attempt to gain control back over a difficult situation. So when encountering any of these types of miracle invocators, there are at least two things that are always required. The first is empathetic imagining, and the second is assessing their understanding. So empathetic imagining is the process of setting aside your own conception of what exists and what is right. That's hard for a lot of us to do, including your own belief about miracles, to move into the worldview of the patient. To do this, you need to understand the patient's physical, psychological, social, and familial circumstances. You'll need to begin with their religious communities, saying things like, "It sounds like church is really important to you. What other activities do you most enjoy these days? What would you do if you couldn't do these things?" These questions help to elicit patient values. And during this empathetic imagining, you may hear the invocator state some incorrect or incomplete medical information. To respond to this, you should decide if the invocator is failing to understand medical information. This is often the case. I always tell my students that once you get into the world of medicine, you forget what real people know and can understand, right? You get into this jargon. And how many times I've heard patients say, no one's ever told me that before. If I say, "Well, you know your father's dying." "What? No one's ever told me that before." And then I'll go to the clinical team and they'll say, "We've told them that 1,000 times. They just don't listen." I think what's happening is not that one party is lying, it's that what is being said is not being understood. So do they genuinely just not understand the situation? Or do they disagree with the team's portrait of the situation? The team says he's dying, but I just don't believe it. I hear this quite a bit right now with COVID because so many people are not allowed in the hospital. We only have usually one visitor at a time, which means that if you can't see what's going on, you might assume it's not as bad as it really is. So you might just disagree. They're saying this, but he's pulled through before. I don't believe it. Or they understand the information, but interpret the illness from their particular worldview. I know the doctors think he's dying, but I know that this is a test of his faith, of my faith. And I have a different way of understanding this illness. So clinicians and ethicists respond to the shaken invocators by assisting in the invocators' process of finding and creating meaning. The clinician should help existential invocators shore up their moral worlds by facilitating some self-reflection, or minimally aiding the invocator to avoid the tragic sense of losing herself. Other healthcare professionals will play a key role in this process. I always advise clinicians to consider having the hospital chaplain come in if they feel uncertain about how it is that they should engage in these deeply religious conversations. In the unshaken category, the strategic invocator, again, is intending to use religious language to further non-religious interests. Underlying this may be a mistrust in the healthcare system or in clinicians. And this mistrust might be justified, as we just heard in our last panel. Perhaps they've had bad experiences with healthcare in the past. So for this group, you will need to attempt to rebuild trust. You want to use their name. I know this sounds so simple, and I know you've experienced it. The clinician just doesn't remember your name. And as we heard, can feel incredibly frustrating, right? Or when I'm on rounds, honestly, we hardly ever use names. It's, the dialysis patient in bed 3. You sort of get reduced to your diagnosis. That's pretty common. Reminding clinicians always how important names are to everybody, including themselves. Sit at eye level when conversing. How many times have you had your physician standing while you're sitting, talking over you and at you? We train them not to do that, but it's still pretty common. And display empathy in the face of hostility. And this is incredibly hard to do and is becoming more and more of an issue, I think, right during these times. People are mad. And it's really, really hard to be yelled at for something that really isn't your fault. But always remembering that this might be the worst time in this person's life. They're sick and they're hurting, and that your empathy shouldn't run out for them. I think, and we can maybe talk about this in the Q&A, but what I'm constantly reframing for our clinicians is especially those who are feeling overburdened by caring for their COVID patients right now, they're burned out. They're seeing 4 or 5 times as many patients as they usually do, and their sympathy for those unvaccinated is running out. Reminding them that how important empathy always is. So for those, in all these conversations, we want to actively seek the invocator's input. So don't allow anybody with who's really aggressively pushing for miracles to be sort of passive in the care plan. We want to always give them an active role. People need to feel heard in medical decisions for themselves or for the person that they're making medical decisions for. And as much as we can, we try to set timetables. So what are we willing to try next and for how long? And when will we meet again to discuss whether the treatment plan is working or not working? So for those integrated invocators, the clinician should be conversing with the patient's faith leaders and trusted authorities. So I have found that 2 practices can lead to some ethically acceptable solutions for these families. So first, again, working with their established faith communities. And I'll say it's not uncommon that someone expresses a faith in miracles or asks for some sort of medical treatment based on faith beliefs, and when you invite in their congregational leader, they will disagree with that stance. Sometimes they will fully agree that this is the appropriate response from our faith tradition, and sometimes they won't. I worry, and we'll get to this at the end, that our clergy are not talking about these issues with their congregants well enough, because they come to the hospital with some very unusual perceptions about what their religion demands of them, things that actually are not demanded of them by their own tradition. So again, with this group, we want to work on time-limited trials for specific interventions, create goals that are either met or missed within a mutually acceptable time frame, and have an explicit plan for what to do if the patient gets better or if they get worse. The second practice, which might sound unusual, but I think can work in a lot of scenarios, is to talk about the patient's conception of death. So even if latent, most of us do have a differentiation between the living and the dead. If I have a good relationship with a patient or a family, I might say, I'm going to ask you a hard question, but one I bet you've thought about quite a bit. What will the patient's dying or death look like? If the invocator is uncertain, you might give them some prompts for reflection or examples, like, some people think that if their heart stops, they've died. Others would say that if their body can't regulate blood pressure or breathe on their own, then they're dying. Have you thought about what death looks like? And I think the reason that this is helpful is because we do have a conception that most religious people don't try to bring people back from the dead. I will say in my career, I've experienced it once, where a patient was dead and being wheeled to the morgue, and the family continued to pray for a resurrection. But for the most part, this is very unusual. Once a patient is dead, that is when a family knows that it's time to give up that hope for a miraculous recovery, or when the patient is actively dying. And so establishing what that will look like and how we know we've gotten there, or what we will know to look for when we're in that process, can be really helpful. Not so we give up hope, but that we can start changing the care plan when that happens. So I've often heard families say, we aren't at that point yet, right? So when I start prompting, what do you think your mother would want if this does get worse? I think that she's in a state now where we really need to talk about advanced care planning. We really need to decide if we need to continue this treatment or not, and we aren't there yet. So how can we prepare them for what there looks like? In these cases, it's important to establish markers for how we know we've gotten to the point of death and dying. We need to know what we're looking for. And we need to be able to discuss what we'll do when we get there, or what we're willing to do in order to avoid death, or what we're willing to do to ensure that the patient has a peaceful death. Okay, so because I'm a good bioethicist, I have some case studies for you. And it will require a little bit of interaction. I will require you to shout things at me. Are you okay with that? You're all masked, it's okay. Okay, so this is our first case. Mr. C, and these are based on real cases, but of course they've been de-identified to protect identity of patients. Mr. C is a 30-year-old Latino man with short bowel syndrome. Being unable to take sufficient nutrition by mouth, he has lived his adult life with a feeding tube. Mr. C has decided that he would like his surgeon to remove the tube. He says, I don't want to suffer like this anymore. I want to seek the kingdom. I don't know what God wants from me. If a miracle occurs and I change my mind, God saves me, or some new, better therapy comes along, then that's fine. But I think I would rather starve and die than continue like this. Bioethics cases are rarely fun or pleasant. Just to warn you, these will all be difficult cases. Okay, so given Mr. C's situation and what he has just told you, do you have a sense of where he might be on this table?
Taken
Yeah, shaken, existential. We all agree? Yeah. Hopefully existential, hopefully not tragic. Yes. So he's clearly shaken, right? Something is going on with him. And he says, I don't know what God wants from me. I don't even know what a miracle will look like. I just know that I don't want to suffer like this anymore. Now, any patient can request to remove any treatment for any reason, and we need to honor that. As long as he has the mental capacity to request that, we do have the obligation to honor it. That doesn't mean, however, that we say, okay, and get his feeding tube right then and there. We might want to have a conversation first. All right, so this is his right, but he seems shaken. This seems like this is an odd request. You cannot live without nutrition, so removing the tube would mean he would die. So what would you do? Is anybody perfectly comfortable removing the tube right after hearing it? No, you're giving me this face like everyone in the audience is like, no, I'm a little uncomfortable. Is anybody like, no, he doesn't have the right to say this? No, that doesn't seem quite right either. So we want to engage in some conversation with him. He's clearly shaken. He wants to discontinue life-saving therapy. And now we need to understand his reasons. So he says he's suffering. So first I want to ask him what he means by suffering. Is he in pain? Is his suffering existential? It seems like he might be upset with God. Does he need spiritual counsel? We should inquire about this. So not all suffering is best solved by the medical team. Hopefully not a controversial statement, and yet it can be in medicine. Not all suffering is best solved by the medical care team. In Mr. C's case, we wanted to invite his priest to come talk to him. So in this case, I suggested that Mr. C talk in detail with his trusted Catholic authorities. And a few days later, after speaking with his Catholic priest, a spiritual care advisor, a clinical ethicist, and his surgeon, Mr. C decides that he will continue with his feeding tube and that seeking the kingdom can mean more than just preparing for heaven. So, and I don't think that this was a manipulative sort of process. I think it was a genuine, we need to reach out to your authorities. Most of us probably know that it is not within the Catholic tradition to say no to these kinds of therapies, that would be something you'd want to get a priest involved with. And so when we did, and he was able to have that conversation with his trusted authority and the clinical care team, who expressed that they were concerned. Sometimes just expressing concern. Physicians are sometimes unwilling to do this because they feel like it's going to manipulate their patients. It's totally my patient's decision, and if I tell them what I think about it, that's unfair to them. I will try to advise physicians that's not true. Your recommendation is really important, and if something feels wrong to you, you should say so. And in this case, nobody felt comfortable with this request. And it was important that they voiced that. Even if ultimately he did request it and we did honor it, at least they could have said, this makes me uncomfortable and let me explain why that is. So this had a somewhat happy, I'm gonna give you sort of cases that have somewhat happy endings, and then we can talk about the ones that had really unhappy endings. That good balance there for the bioethicist. Okay, so this was the table of how we sort of thought about his invocation, responded to it with his care team. Okay, so case number 2. Mrs. A is admitted to the MICU, that's the Medical Intensive Care Unit, due to respiratory distress related to complications from pancreatic cancer. She's placed on high flow oxygen, so she can't breathe, so she needs supplemental oxygen. I think at this point she's almost maxing out. So she needs so much that we think the next stage would be a ventilator. And at day 14, the team tells Mrs. A's husband that supportive treatment has become inappropriate because she has a terminal, irreversible condition. Mr. A says, this is her husband, we must begin a new round of chemotherapy. continue the breathing machine, and start dialysis as we wait for God to perform a miracle and restore her to her happy, active life. She would have wanted it. Our bishops say it is the right thing to do, and we always listen to our bishops. All right, so where do you think Mr. A is falling?
Unshaken.
Sounds unshaken. Yep.
Strategic.
And what?
Strategic.
You think strategic? Why do you think strategic? You have to, shout it out, and I'll repeat it for the folks at home.
Because claims support by the guidance of the established authority.
Okay. So in that case, we might call him integrated. Yeah.
I would agree that it's strategic, but because he's trying to direct medical care based on religious belief.
Yeah, so for both the integrated, for both the integrated and the strategic invocator, they both are intending to direct clinical care based on their sort of claim of a miracle, or their belief in a miracle. So we need to decide at this point, is this sort of a last-ditch effort to gain control? Like, they're saying she's gonna die, I don't want her to die, I'm trying to regain control of the situation, and here's exactly what I want. Or is this a genuine, sort of coming from an authentic place of belief where, this is what my tradition demands of me, to continue these kinds of therapies, right? So how would we know? Well, we might need to ask then, right? So one thing that tips me off is this invocation of the bishops. So I would want to ask about these bishops. What faith community do you belong to? Great. Tell me more about that. And when you say this is what the bishops are demanding, have you talked to them? Should we invite them into our next family meeting? And if they say yes, then they're probably integrated. This is probably coming from their own, what they believe that their tradition demands of them. If they say, no, I don't want to talk about my faith community, I don't want to invite them in, don't ask me anything more about my religious tradition, it might be more strategic. So this might be a case in which you want to dig in just a little bit more. Because again, not that one of those is good and one of those is bad, but that one of them needs to bring in the religious community to help us, and one of them we need to talk about trust in the medical team. So we have a different strategy for each of those groups. So in this case, he was what we'll call an integrated invocator. So he's clear about his church commitments, and we want to explore these views. So when we did talk to Mr. A, it became clear that he wanted members of his church to come to the hospital to support him and his wife and to meet with the medical team. So a clinical ethicist and a spiritual care advisor met with Mr. A, members of his church, and the apostle who leads their congregation that their family's been a part of since they immigrated to America in the early 90s. And Mr. A insists that if Mrs. A could speak to the team right now, she would want us to keep praying for a miracle, citing the resurrection of Lazarus as evidence for his claim. So the church representatives ended up agreeing with this assessment. So you go, oh no. 50-50 in my experience, whether or not the church community is going to agree with this kind of assessment. So what do we do now? So first, as tempting as it is, we shouldn't debate Mr. A's theology. We want to explore his faith and his worldview, but we don't want to talk him out of his theology or discuss our own lack of faith. I've heard many physicians interrupt and say, well, I don't believe in miracles, but, and like, maybe that's not the way to establish trust with this family. Not to say that I would never recommend saying you believe something that you don't, but being really aggressive with your lack of shared belief is probably not the best strategy either. So instead, the team might work with Mr. A and his religious community to establish some agreed upon time trials for specific interventions. Concrete goals are either met or missed within a mutually accepted time frame, with an explicit plan in place for either outcome. So as best we can, we wanted to avoid making unilateral decisions about Mrs. A's care without involving her husband. So even though he's demanding some really aggressive things that we don't agree with, and it might just be easier to leave him out of the conversation, we want to avoid this. This will only strengthen his mistrust in the medical team, and we need to be able to work with him productively and involve him and his pastoral care faith leaders when possible. So in this case, after some lengthy discussions, Mr. A agreed to a time-limited trial of dialysis and a ventilator before deciding whether or not his wife would need a trach. So a trach is a more permanent breathing machine that she would likely never get off of. So she would have probably died with that trach in. Or we would have had to decide when to remove it, and that would have been the thing that prompted her death. So the team assured Mr. A that they would do nothing to prevent the miracle that he hoped for, but they were obligated to only use therapies they believed would benefit his wife. So we will not prevent the miracle, but also we have professional obligations to your wife that we have to meet. You have to be her advocate, and we have to practice responsible medicine. So after a few days, they recognized that she was approaching death and feared that she was in pain. And the palliative care team was able to make Mrs. A more comfortable. And her husband eventually recognized that she was in the process of active dying, allowed the palliative care team to come in because we had established what that would look like ahead of time. And she was able to die peacefully in the hospital with her husband by her side. This isn't the sort of outcome that he had really hoped for. He really wanted her to get better. And ideally, she would have probably gone home to die. Most people would rather die at home. But this was sort of the solution that could be mutually acceptable to both parties. So again, a happy outcome. In bioethics, this is a happy outcome. So we were able to allow her to die peacefully. And I'll tell you about some less happy outcomes in the Q&A if you want to ask about those. Okay. So this is case number 3. So Mrs. B experienced a series of seizures and is now sedated. During a family meeting, her neurologist floats the possibility of therapeutic hypothermia that might, quote unquote, restart Mrs. B's neurological system. If this procedure doesn't work, the neurologist says, then Mrs. B will likely live the rest of her life in a minimally conscious state. This is actually kind of a newer diagnosis. So a lot of people have heard of a permanent vegetative state, or PVS. That's when you have permanent unconsciousness, but often you're still able to breathe. A minimally conscious state, you do have some minimal awareness of your surroundings, which can come and go. Most people would not want to live forever in that kind of state, but some might find it acceptable. The patient's oldest of 4 sons, Mr. K, exclaims, "We have to try it." When asked to expand on his rationale, Mr. K at first isn't able to give a reason beyond repeating, "We have to try everything." Near the end of the meeting, he exclaims, "God will work a miracle for my mother if we pray on it hard enough. I know it. My brother and I will pray over her, and a miracle will happen. You can't disrespect me and my faith. It's discrimination." Okay. So where do you think he falls? You think integrated? Shaken integrated, or unshaken integrated, sorry.
You need more information.
You need more information. Okay, great. So this is half the role of the bioethicist, is just asking the right questions. So what would you need to know if he were integrated or strategic? What would you want to ask? Yeah, so I'd want to ask about his faith tradition. So I might say, I understand that it sounds like a miracle is really important to you. Can you tell me about your faith tradition or your faith background? In this case, when we asked him that, he said, I was raised a Lutheran, my mom's a Lutheran, I don't really go to church anymore, but I still think that miracles can happen. And you can't deny me my faith. Right? So in this case, when we sort of pushed him on this question, he didn't want to talk about his faith tradition much. He didn't want to bring in any faith leaders. What he really wanted was to sort of assert his right to religious belief. Right? So we do know in this country we have a lot of protections for religious liberty. And those, I think, in most instances are a really good idea. But they can also be used by people who want to sort of claim something or claim authority because they recognize that that's one way to do it. So you can say all you want about medicine and science, that's fine, but I have my faith and you can't deny me that. To do so would be discriminatory. So you sort of, when you hear that language, you think, well, maybe this isn't coming from a place of his faith community. Maybe this is sort of a strategic invocation. I want to go back to this. This is what I would call a failed family meeting. The neurologist floated a care plan that he wouldn't actually have recommended, and it created hope for the family that might have been a misplaced hope. So it's not uncommon. So a lot of physicians believe that they have to offer an array of options to their patients because that's what's required of them. So we don't want to go back to those days, as our chaplain was saying, when medicine was completely paternalistic and you just did whatever the doctor said. That actually, there are patients who would really like that. I don't want choices, I just want the doctor to decide for me, and that's perfectly acceptable. But a lot of us would want some choices if there are choices to be made. Unfortunately, then, some physicians will offer choices that they actually don't want to do. They actually think would be wrong choices. And in which case, they might have just floated an idea that now the family is clinging on to. So now they have this hope of a miraculous cure for her from medicine that now no clinician actually thinks is appropriate. Do you have a question?
Yeah, more of a comment.
Yeah.
I think that you make a great point in terms of discussing how floating around an idea that is false is going to be put into the patient's head that they when you're dying or something, you don't know, like what you said, you are not cognizant of what's going on.
Mm-hmm.
So putting false hope and then trying to play God
Mm-hmm.
at the same time is a bad combination.
Mm-hmm.
And I think that you hit around the head that you live in a society that tries to, I think at the other panel, they spoke about how you have to have trust
Mm-hmm.
in the medical system. I think that is the key to understanding how,
Mm-hmm. Yeah, so the comment was that it's inappropriate to create this kind of false hope if you're floating ideas that you actually don't think really have a chance of working, or you wouldn't have any faith in yourself as a medical professional, that would be inappropriate, and that this creates kind of more mistrust. Because suddenly we just said, well, we could do this, but we're not going to do it, we're not going to offer it. Oh no. Then why did you mention it? So if we're not really going to offer genuine options, we shouldn't mention them. And in this case, the clinicians in the room just looked at this neurologist like, why would you say that? He said it sort of offhandedly, and now this is all the family wants. And now they feel like there is a viable option that is being withheld from my mother. They don't really want her to survive. They just want to get rid of her. I hear this all the time. They're just trying to get rid of her. Why would they have they told us there was something that could help her, and now they're not letting us choose it. This creates incredible mistrust between the family and the clinical care team. And reestablishing that trust is going to be incredibly difficult and a very, very lengthy process. We might not actually have time to do that before she dies. which is tragic. So we could have just undone, often when I'm involved in these cases, weeks of really thoughtful deliberation about the best thing to do is totally upended by one clinician's suggestion that something else could work. Yeah. Don't you want to be bioethicists now? I actually, part of this was students should consider becoming bioethicists. But we have this, this just is the reality of hospital spaces. In this case, we had this failed family meeting. Mr. K was insisting and refused to discuss any other care plan besides this care plan. So in this case, we needed another family meeting, one in which the clinical care team had to come together ahead of time to agree on what they would even offer this woman and what they would recommend. So during the family meeting, the ethicist should work to ensure that the team's portrait of the patient is understood by her son through summarization and actively seeking his input. And as best we could, we tried to reestablish trust with Mr. K by involving him in all discussions about his mother's medical situation. And it's important to realize that this strategic invocator may have justifiably lost faith in the patient's team's ability to deliver beneficial care. So in a second family meeting, we learned that Mr. K had lost faith in physicians after his father died, having a minor surgical operation. So Mr. K always suspected that his father's death was the result of a medical mistake that no one ever owned up to. He also believed that the medical care team never told him the whole story because he was poor and he was Black. So he didn't trust medical professionals at all. We had to address these concerns with Mr. K's lack of mistrust and address his role as a surrogate. So we reminded him that his duty was to represent the views of his mother and not his own. And then we made sure that he understood the risks and benefits of the procedures that the medical team was willing to provide, so he understood the full medical situation. So, because they couldn't take it back, eventually the care team did agree to therapeutic hypothermia, and it was unsuccessful. Mrs. B was minimally conscious afterward, but as she declined, Mr. K did agree to enroll her in hospice so she could spend her final days receiving comfort care at home. So again, not the most ideal outcome, but one that was manageable for this family and that the team could agree to. So this is not to say that we have to always do what the patient or their surrogate wants. There are points at which we're allowed to override a patient or their surrogate because what they're requesting is just so harmful to the patient. This is typically more what families will do. They'll sort of insist on just the most aggressive kinds of treatment, even when the medical team feels like they wouldn't benefit the patient at all. And when that is the case, we write hospital policies that allow us to override decision makers in very limited circumstances. So this non-beneficial treatment policies help us to sort of make sure that we're doing the right thing. In Texas, we actually have this built into the law, which is interesting. I think we're the only state that has a futility law. But what we have to do is when somebody requests treatment that the physician believes would not benefit the patient at all, we have to get a second physician to agree that that's true. We have to get ethics involved to review the case. We have to offer transport to another hospital. So we call around to every local hospital and see if anyone will take this patient. They very rarely will, because if their treatment is futile, nobody else wants to do that. But we have to try. We have to try for 10 days. And after that period, we're allowed to say no and remove or withhold the treatment that we think would be non-beneficial. And almost every hospital will have some sort of policy that allows them to do this. It's rarely totally followed through, because hopefully in the meantime, we can reach a mutual decision about what should be done. We hate overriding patients and their family members, but sometimes we feel like we're torturing patients to death. That would be the worst thing for our clinical care team. This isn't working and it's hurting her. Most end-of-life treatments, if they're not benefiting, are hurting. So, most of you are not physicians or bioethicists yet, but I would love to convince you that maybe this is a career you should have. But I do want to talk a little bit about those of you who are going into pastoral ministry, hoping to one day be pastors or already pastors, how you should prepare and counsel your parishioners for difficult end-of-life conversations. So one thing I've done with congregations is to talk about advanced care planning. So for many of us, this is a pretty uncomfortable conversation. As the panel said, we don't like to talk about death. But as Christians, we know that we're going to die and that we're not to fear death. Interestingly, Christians are more likely than any other group to request aggressive end-of-life care, despite having the most robust vision of the afterlife. Now, part of this might be explained by our belief in miracles, and part of it might be a fear or mistrust in medicine. Either way, the trend needs to be reversed. And not just because we reject medicine, but we know that those who request the most aggressive care at the end of life tend to die sooner and in more pain. The more aggressive your end-of-life care is, the more life-limiting it is, both in days, but also in quality. It's just not good to receive the most aggressive kinds of care right at the end of life. Palliative care and hospice actually have been shown to extend life, extend the days of your life as well as the quality of your life. And this is what we would want for most people at the end of life. And people who request kind of aggressive care at the end of life are more likely to receive costly, needless procedures that place themselves in anguish and their family members as well. Watching somebody die with all the machines hooked up and in visible pain is the worst way to watch somebody die, or so people tell us afterwards. So there is important spiritual work to be done at the end of life, and we might make that work impossible if we seek out the most aggressive kinds of care at end-of-life treatment. So those who refuse to acknowledge the end is near are also less likely to say goodbye, are less likely to tell people that they love them, are less likely to make amends with people that they've hurt. Only by acknowledging that death is near can we say the most important things. I love you. Thank you. I forgive you. Please forgive me. So we don't have control over how we will die, but we can help prepare our families and loved ones for our death. By having critical conversations about what we would want near the end of life is one way that we can prepare our families. So in my experience, most family members, when asked, really have no idea what their loved ones would want, either in terms of medical care or even basic caregiving. So help your congregants to think about what medical procedures they might be willing to endure for a few extra weeks, days, or even hours of life. But also what would make them comfortable. Music, massages, reading scripture. I like those things. I actually have my advanced directive says that. I want my husband to rub my feet if I were dying, because I like that. And it's one way he can participate in my care. These are small comforts that we can offer without being a member of the medical team. So next, have conversations with your parishioners about what faith requires of us when we're sick or at the end of life. Does God test us with illness and suffering? Must we endure suffering to be faithful? Does choosing to forgo intensive medical care mean we're giving up on life? That we no longer trust God? You might be surprised how many people in your congregation do feel this way, even if it's not the official teaching of your church. It is not uncommon when I invite pastors into the conversation that they correct these kinds of theological misunderstandings. Next, talk about miracles with your parishioners. Does your tradition believe miracles still occur? And if so, what form do they take? Does a miracle only look like an unexplainable cure, or are there other ways to see miracles in our lives? How common are miracles? And should we expect them and make decisions based on our hope for them? And finally, talk with parishioners about how they will know when they've received their awaited miracle. Does God declare it from on high? Wouldn't that be nice? Your miracle has been granted. Stop asking for more miracles, Devan. Will God's voice be really clear? Or are there other ways that we experience God's grace and wonders when we need them the most? Here's some of my collaborators on this project. But thank you.
I have a question here from the talk from Dr. Tim Manis, who says, Professor Stahl, could you please give another example of a patient invoking miracles in a tragic context as opposed to an existential one? I'm afraid I'm not grasping the difference between the two.
Yeah, so the only difference is that the existential invocator will come to some sort of resolution, and the tragic will not. So often you're sliding between the two categories. So it could be the same exact invocation. So it could be the same case of saying, I don't know what to do. I hope there's a miracle, but God seems to be testing me and I don't know what for. Wasn't I good enough? I hear this. Wasn't I faithful enough? What do I need to do? I've had people try to get me to help them call like televangelists, to donate money to organizations, to do anything they can, because they do not understand why they're suffering, why they would be dying in this way. And in those folks, what makes them existential versus tragic is just their ability to come to a resolution on that. You know, so our goal is to help them think through, you know, were you mistaken about this belief, or is God really trying to punish you? And if so, why would God do that? What is your understanding of God that you would think that God's punishing you, right? What are you regretful? Sometimes it's this deeply held regret about something they had done in their lives that they never wanted to admit to. Sometimes it's feeling like they could have changed a situation that maybe they couldn't have. And really it involves, again, those things of gathering around the people in your life who you need to say I'm sorry to, and who need to sort of forgive you. And in those cases, you can sort of rebuild that sense of self, and you might change your mind about what your worldview is, or about who God is, or what's required of you, but you come to a kind of resolution. But there are some who never do, and they will die tragically, never having understood why God was allowing them to suffer the way that they were suffering. And so that's just the only distinction, is that were they able to come to a resolution or not in the midst of that suffering? Mm-hmm.
Yeah, thank you so much for an awesome talk. You had this really provocative photo of the physicians, the surgeons standing around, you know, appearing to pray. Mm-hmm. I think this raises, I think this is an interesting point, which is, you know, your talk focused really a lot on, say, the patients or the patient's family and their belief in miracles and what they're bringing into this, say, end-of-life situation. Can you talk a little bit about how the doctor's beliefs factor into this? Obviously, as an ethicist, you're in a room not only with the family, but the physicians are bringing their beliefs, whether religious, whether non-religious, to this as well. So could you talk a little bit about the intersection of, or the conflict between, say, the patients and the beliefs of the doctors?
Yeah, so like I said, so at least in my experience, physicians aren't quite as willing to bank on the miracle as the patients are, or to hope for it in the same kinds of ways. Even though I think a lot of religious physicians would say, yeah, miracles do happen, they would probably fall into, and I'd be curious what you all fall into, maybe like number 2, that, yeah, there are exceptional cases in which nothing explains this, and maybe it's a miracle. There's also a difference between unexplained and unexplainable. It might just be that we don't understand. I think most religious physicians I know will fall into this sort of second category, whereas we are encountering a lot of patients who are falling maybe into the third category, who have maybe more of a charismatic or Pentecostal background, or even some evangelical backgrounds will have this kind of view of like the faith itself is aiding in the performance of the miracle. That's really rare to hear from a physician. But I think even the non-religious physicians want to respect this sort of belief system. I actually get more concerned about the physicians who, let me clear it up for them. These are the physicians I worry about the most, the ones who are willing to debate the theology of miracles, the ones who are most willing to say, well, that's misguided. Let me explain to you what a miracle really is. And I have certainly encountered that. And who are those? Those are the good Christian physicians who are most willing to do that. I think that's a mistake, right? And for all the reasons I mentioned, imposing your own belief system on a patient, which they would never do in any other circumstance. I think it's when your faith beliefs and the patient's faith beliefs seem closely aligned that physicians feel the most comfortable sort of correcting theological misunderstanding. And I think it's rare, but it does happen. And I always try to convince them that that might not be the best strategy. And chaplains are really good at convincing them that that's not the best strategy. But those are actually the situations I get most nervous about, because you can create incredible mistrust by assuming that you're talking about the same thing and that you have the same belief system, and that because you're the physician and you have that kind of authority, that then you'll have the same kind of authority over their religious beliefs as you do over their medical care. And that actually might work for some patients. Oh, well, he is a smart doctor and he knows what he's talking about. But it can also really backfire. And then suddenly they're persecuting this physician is persecuting my religious belief. And that's really, really hard to come back from. So I think being sort of sensitively engaging and assuming that we don't have the same perspective is a better sort of approach. And then if we do, we can sort of talk that out. But I would never assume that we're talking about the same thing and that I have any authority or right to sort of change your mind about this. So many physicians do sort of believe in extreme circumstances of miracles. And many, I think like we heard on the panel, have this sort of fourth understanding where miraculous things happen all around us, just pay attention. But they don't base medical treatment plans on those hopes, on the sort of rare extreme hope, whereas patients are much more willing to do that and their families are much more willing to do that.
This question comes from Robin Day. Robin writes, I am a physician in primary care, and I have been struggling bringing forth discussions of advanced care planning, even having gone through training. Even when we schedule appointments for ACP, you probably know
Advanced care planning.
Thank you. We talked about acronyms earlier.
Yeah.
Patients often don't show up. How can I make this easier for myself and patients?
Yeah. I mean, I do think, and hopefully this is why I want pastors to get involved, because I think that physicians sometimes just aren't the best people to have these conversations. It's actually, I think the ideal place is another place in which there is a physician and another kind of trusted community authority who are having a conversation together. Because that people want these kind of conversations to happen in community with people that they trust. And often we don't have the kinds of relationships with our physicians where we think of them as just regular people that we trust and have good relationships with. A lot of us are pretty distant from our physicians, and if the only time you're ever hearing about advanced care planning is when you come into the hospital, it's suddenly ooh, are you saying I'm gonna die? Right? There's that perception of the angel of death, as our chaplain said. So that can be a difficult space. So I think the best place for these conversations to happen would be in churches, where you have a physician from the community who can help answer those medical questions that people might have, but then we can talk about our values in a space that's not so most physicians will spend 4 minutes with their patients in the hospital if you're hospitalized. That's not a lot of time. And so if you get a little bit more time to even talk about advanced care planning, that's already in itself a gift, but not everyone's willing to do it. Only 25% of Americans have some sort of living will. About half of them will never share it with their care providers. Yeah, so it's just incredibly, we've spent a lot of money trying to push advanced care planning, and it doesn't seem like it's been all that successful. And I think because we've put the onus of this completely on our medical systems, that people don't necessarily trust. And I think there's other people that need to take on this burden. So I still think physicians should bring them up. I think especially with patients who are chronically ill or have a terminal illness that we can sort of predict what their end-of-life course might look like. Those are the patients for whom it is most important that we're really pushing advanced care planning for them, because we want them to die in a way that's dignified and the way that they want. But for the rest of us who are not in that situation, we should be having these conversations in other spaces, would be my advice. Yeah, I mean, so where would the space be? I mean, for those of us who are part of a religious community, I think it should happen there. So I've run this, and actually, every time I've offered to do this with a congregation, they've been really excited about it, like way more excited than anyone I've ever talked to at the hospital. So I do think there's something about that space that it creates a different space. So it's usually me who understands the document really well. If there's a physician in the congregation, I want to invite that person, and then the pastor. And then you get like a group together somewhere in the church we pass out the documents, we read them over together, we help answer questions, and then they choose whether or not they want to fill them out, but at least they're talking. And great conversations happen in those spaces. It's a place where people can, this is how my mother died. This is how my sister died. I never would want to die like this. And it's a space then where people are hearing what you say. Because the other problem with a lot of living wills is that people write them and never talk about them with their family, and then suddenly the family's like, what does this mean? I have no idea what she meant when she wrote this. So you need to have that actual conversation. So if we're part of faith communities, it can happen there. The other place it's happening in non-faith communities is like death cafes, in which communities are getting together at usually bookstores or coffee shops and talking about death. So those are other spaces, I think. You'd be surprised if you just put out a notice like, hey, we're going to talk about death and advanced directives, how many people might show up.
Yeah, with a document like 5 Wishes,
Yeah.
makes it very acceptable.
Yeah, I love 5 Wishes. If you're looking for a good advanced directive, they're not legally binding in Texas, which is unfortunate. But that's actually the document where it says things like, please massage me with oils. I'm like, yeah, please massage me with oils. That's lovely. Why don't all, because most advanced directives are just like, if you are in a terminal or irreversible condition, would you want a feeding tube? Yes or no, right? And so you're making these like really esoteric kind of medical decisions, but you're not telling people like what your values are or what kind of end of life scenario would be most desirable. And when I get 5 Wishes documents, I'm always like, oh, thank goodness, because it's really informative for the families and the medical care team. So if you haven't heard of this, you can just look it up. But it's multiple pages of you just thinking about all sorts of really deep questions about your life and your values, and what kinds of things make you comfortable and make you feel cared for. I always joke that every now and again you get a 5 Wishes where somebody will be like, do not sing to me. And I always just think that that's really funny. There's like, nobody's allowed to sing to me at the end of my life. And they're like, oh, good to know, because actually we have people who come around and sing to people, and it's good to know that you wouldn't have wanted that. And I would only have known that from your 5 Wishes document. Mm-hmm.
I thank you very much for coming all the way from Texas and all that. I might go to law school there. I'm not sure yet, but we'll see. I think that God works in mysterious ways. He is a faithful God. He is a God that does wonders. Mm-hmm. And I think that, how do we don't know what God will do, I think. And I think that we have come to a point in time, especially in the medical field, where, like a lot of the panelists that are here today, we have become untrustworthy mm-hmm. of medical professionals, I think. Mm-hmm. And how do we trust God in that when the bishop or the physician or the care provider is trying to tell you that this will work because God said so?
I mean, this is a sort of tough. I do implore people to sort of take no one knows better about the sort of medical prognosis probably than those physicians working on your team. they're really not there to trick you or fool you or get you to die, or, there are a lot of these, like, they're just trying to push me out, I'm too expensive. I promise you that, physicians don't even understand insurance themselves. Like, they don't know about it, they don't ask about it. The only time a physician ever looks at what kind of insurance you have is when they need to discharge you to another facility, and that facility will take certain kinds of insurance or not. Your ability to pay, your immigration status, none of that is ever considered by your physicians. That doesn't mean that physicians are always right and that you can't sometimes push back. So this is a tricky space, because I want you to trust the science and I want you to trust your physicians. But in my job, I sometimes have to push the physicians to say, I actually think you might have a bias here that's leading you to recommend a care plan that is not best for this patient. And I guess be thankful that there are folks that are able to do that and be heard in a lot of our hospital systems, so that there are bioethicists who have the kind of clout and authority in those spaces to say, hey, this sounds actually like a bias. And at the beginning, Zach mentioned that one of my research areas is disability. And I know that statistically, there was a big study that just came out from Lisa Iazzoni that showed that I think it was 74% of physicians believe that patients with severe disabilities do not have as high a quality of life as more able-bodied people, which all the studies show that that's not true, that people with disabilities have as high a quality of life. And only about half of physicians feel like they treat people with disabilities equally as people without disabilities. So there's some disturbing kind of biases that do exist. And so those are some spaces where I tend to push back and say, hey, are we assuming something about quality of life that's not true? So there are times when I think it's okay to sort of push and ask those questions. Physicians aren't always right, and they're human beings, right? Medicine is also it's not a perfect science. It also is an art. It also has to be applied, and we're not always sure. Like, no one can say 100% that you're definitely gonna die in the next hour. Like, no one's willing to say that because we just don't know. So we have to guess, but these are well-informed guesses. So I think taking the medical facts, taking our own sort of understanding, pushing against some potential biases. If you don't know this, most hospitals, you can ask, as a patient or a family member, ask for an ethicist to review your case. And so I get calls from patients sometimes, and I will take those very seriously. And so having somebody else say, do you have an ethicist? I'd love an ethicist to look over this, because I feel like something's not right here. That might be another good option. So I think, physicians are doing the best they can, but they're human. Trust that they probably know the most likely outcomes. And then, if you're really worried about some sort of decision, ask for somebody else to intervene, a patient advocate, an ethicist, maybe a chaplain. I think there's other professionals who can help balance out that authority of the physician. I hope that response didn't anger physicians. But they know we're not everyone. No one's perfect, right? We're still human beings making decisions.
Do we, as consumers of medical services, have an obligation to get together with our doctors and medical care providers before these situations come up?
I think you should. So the only way, like I said, even people who fill out advanced directives, sometimes I'll talk to them and they'll say things like, oh, I'm not going to share that with my physician. That's private information about me. And I say, oh, well, that's a misunderstanding, because if you don't share what you want with your physician, they're not going to be able to implement it. So even if you have a document, if you don't give it to the medical, establishment, it's kind of meaningless, even if it's been properly filled out. So you need to have these conversations with your physician. The other problem with a lot of advanced directives or living wills is they're really hard to interpret. And so if you haven't talked about what you meant when you filled something out with a physician, they're just guessing, right? So they're not self-interpreting documents, even though they seem really specific. So there are many times in which we will override, even though the advanced directive or the living will typically will be statutory, like it'll have legal authority. If somebody comes in and says, oh, my mom didn't mean that when she wrote that, she meant this. If they have a good reason to say that, if they have a good story, I'll say, well, okay, then maybe we shouldn't do what this document says, because somebody's interpreting it differently. So if you're concerned that that could happen, you definitely want to talk to your physician or say, this is what I would want. All that should get logged in the medical record, and so we have evidence of what you would want. So I would say definitely have those, especially with your primary care physician. When you're getting your annual checkup, it would be incredibly beneficial down the line to say, what it is you would want in cases where you couldn't speak for yourself or you were at the end of life. Will you please put in my medical chart, blah, blah, blah. And then other physicians can look that up. By having that documented, that is the best and easiest way to then follow out what it is that you really want. And I will say some people, on the Texas Advance Directive, you can write in something like, but my family can override this if they really want to. Which for some people is very comforting. Some people, how many of you, if you're making a really, really important decision, ask a member of your family or someone that you love if you're making the right decision? Right? Like most of us don't sit in a vacuum making life or death decisions without consulting anyone. And a lot of us might change our minds about those decisions with family input. So that's also something you could write into your advance directive. If my family really doesn't want to honor this, I give them authority to override it. That's really comforting to some people. Because, I think at the end of the day, it is nice to have that documentation, because then you're not worried as a family member, like, what if I'm not doing what they really wanted? It can be comforting to know what you really wanted. Sometimes it can make it more difficult. So I think being clear with your family and being clear with your care providers that creates a situation and you're most likely to get what you want.
Well, I want to say thank you for coming all the way out here to beautiful Pennsylvania and for spending this time with us and sharing your brilliance and expertise with the rest of us. And if we could all give you a round of applause.